Apert syndrome is genetically inherited and it is characterized by craniosynostosis and bilateral syndactyly of the fingers and toes. Craniosynostosis causes many of the characteristic facial features of Apert syndrome. And just to recall on what craniosynostosis is, it's the premature closure of the cranial sutures. Eugene Apert was the first to describe Apert syndrome in detail in 1906, and this is where he described 9 people with similar facial characteristics. Some of the clinical characteristics include hypertelorism, bulging eyes, underdeveloped midfacial regions, palate abnormalities, so for example, a cleft palate, asymmetry, flattened nose with a low bridge, delayed teeth growth, dental crowding, or an open bite, moderate to severe acne, and hyperhidrosis. If openings between the nose and throat are too narrow or blocked or tracheal cartilage is malformed, this could interfere with an individual's breathing or swallowing and can result in upper respiratory tract infections, sleep apnea, and malnutrition. So as you guys can see here, I've included 3 photos of what midface hypoplasia would look like in a child with Apert syndrome, a child with hypertelorism, and a child with dental crowding. The hands in Apert syndrome will always include fusion of the middle 3 fingers, and the thumb and 5th fingers are sometimes involved. So here you guys can see a picture of what that would look like. Progressive synostosis is common in children with Apert syndrome. Non-progressive ventriculomegaly is also present, with 60% of Apert patients having non-progressive ventriculomegaly. Feeding issues are common with a number of causes. So for example, palatal anomalies can cause difficulties with generating suction, therefore with difficulty intake of sufficient food of volume, narrowing of the choanae, I think that's how it's pronounced, or nasal turbinates can cause respiratory distress. This can be mistaken for feeding issues. Risk of GI issues can cause vomiting. Hearing loss is also very common in children with Apert syndrome, with 80% of them having conductive hearing loss. So this can be caused by middle ear infections, ossicular abnormalities, and external auditory stenosis or atresia. Children with Apert syndrome's airway may also be obstructed, and this can be due to narrowing of nasal passages, the tongue, or tracheal anomalies. So speech and language in children with Apert syndrome. It is expected for children with Apert syndrome to exhibit speech and language difficulties. Many of them have severe deviations in oral structures, hearing loss, and low IQ. Structural features associated with Apert syndrome can affect normal resonance. So for example, many children have or exhibit hypernasality due to the oral pharyngeal structures or a cleft palate. Children may exhibit articulation problems due to oral structure abnormalities, oral motor problems due to malocclusion, irregular dentation, or a highly arched palate, and language problems. Deficits will vary with cognitive level and a child's hearing status. Cleft palate in children with Apert syndrome also causes delayed acquisition of speech sounds. So the etiology. Apert syndrome is an autosomal dominant inherited craniosynostosis syndrome, and it is caused by a mutation in the fibroblast growth factor receptor 2 gene. This gene plays a critical role in skeletal development. It is estimated to occur in about 1 in 65,000 births. And something that I found really interesting is that Asian people have been reported to have the highest incidence of Apert syndrome. There's a short video that I'd like to play for you guys. This video explains how Apert syndrome is caused.
FR2, a gene on chromosome 10, is the Apert syndrome gene. To understand why mutations in FGFR2 cause Apert syndrome, let's first understand the role of FGFR2 in non-disease individuals. The FGFR2 gene codes for the fibroblast growth factor receptor 2 protein, which is a transmembrane receptor that mediates signal transduction from the extracellular to the intracellular environment. It binds various ligands, which is what you call a molecule that's bound by a receptor, called fibroblast growth factors. The downstream signaling is important for balancing proliferation, differentiation, and apoptosis of precursor cells like osteoblasts so that bones are formed in just the right way during development. In people with Apert syndrome, specific missense mutations in the FGFR2 gene alter the 252nd or the 253rd amino acid in the FGFR2 receptor. These are gain-of-function mutations which cause FGFR2 to bind FGFs more strongly and with altered specificity. FGF signaling is excessive and dysregulated, causing osteoblasts to ossify or turn into mature bone at the inappropriate time and to fail to undergo apoptosis or programmed cell death. This results in cranial synostosis and syndactyly. Apert syndrome is either inherited in an autosomal dominant manner, which is less common because the features of Apert syndrome mean that affected individuals are less likely to have children, or arises via a new or de novo mutation. The disorder exhibits a paternal age effect, where the incidence of the disease increases with the father's age. This is thought to happen because of a selective advantage of spermogenitor cells that have acquired these FGFR2 mutations. The features of Apert syndrome can usually be recognized at birth and sometimes even prenatally via ultrasound. An MRI or CT scan of the skull may be needed to confirm and characterize cranial synostosis. To confirm the diagnosis, a genetic test that identifies an activating mutation in FGFR2 confirms the diagnosis of Apert syndrome. The main conditions in the differential diagnosis of Apert syndrome are the other cranial synostosis syndromes, which include Cruzon syndrome, Pfeiffer syndrome, and others. Interestingly, many of these syndromes are caused by either different mutations in FGFR2 or by mutations in the related FGF receptor genes FGFR1 and FGFR3. This underscores the importance of these genes in skeletal development. These syndromes can be differentiated from one another based on exam findings. For example, none has such severe hand and foot findings as an Apert syndrome, or by genetic testing. Unfortunately, there's currently no overall cure for Apert syndrome. The main interventions are surgical. When it comes to skull surgeries, the main goals are to allow the brain to grow, to minimize proptosis, and to improve cosmetic appearance. Key procedures include posterior cranial vault distraction, where the furthest back part of the skull is separated and pushed away to make more room inside. Frontal orbital advancement, in which the bones of the forehead and brow are separated from the rest of the skull and move forward. And Lefort 3 osteotomy, where the bones of the midface are pulled forward. Hand surgeries are also done. However, syndactyly is often severe enough that the end result usually isn't a normal hand with 5 functioning fingers. To summarize, Apert syndrome is an autosomal dominant disorder that features cranial synostosis, differences in facial appearance, and syndactyly, caused by specific gain-of-function mutations in the FGFR2 gene that disrupt the balance of FGF signaling, which affects the way bones are formed.
Okay. Oops, sorry. Okay, so Apert syndrome is diagnosed at birth or during infancy. Individuals can also be diagnosed through clinical evaluations, genetic testings for mutations in the FGFR2 gene, and the features of Apert syndrome may also be detected through parental 2D and 3D ultrasound or magnetic resonance. So as mentioned in the video, individuals with Apert syndrome share many similar features with other disorders, so in particular Cruzon syndrome. Also, multiple genetic conditions may cause similar cardiac conditions and cognitive involvement. Digital anomalies, so like syndactically, are present in Apert syndrome and not in other disorders that share common features. Management and treatment, surgery. So for example, jaw surgery to advance the midface, cleft palate repair may be performed before the development of pressure continence, feeding intervention to evaluate swallowing safety and support feeding, pediatric dental care, surgical interventions to treat sleep apnea, hearing aids for children with hearing loss, and of course, early intervention services and speech language services. So it's important for speech language pathologists to consider that children with craniofacial abnormalities associated with Apert syndrome are at risk for educational underachievement. It's also important that in the school environment, social inclusion is important, as children with visible differences and speech sound differences are more likely to experiencing bullying. So counseling is very important. And working with a child with Apert syndrome will require multidisciplinary care. And these are my references.